So medical diagnosis often rests on determining the current or recent physiological state of the tissues. And no two fluids are more valuable for assessing this than blood and urine. Here we'll focus on urine analysis, which is the examination of physical and chemical properties of the urine. Let's start with the appearance. Urine can be clear, almost colorless, to a very deep amber color. The yellow pigments come from this urochrome pigment, which results from the breakdown of hemoglobin in red blood cells. We'll see other colors that come from foods and drugs or disease. Perhaps you've taken vitamins before and noticed the bright yellow color of urine. We might observe cloudiness in the urine, or blood could suggest a urinary tract infection, trauma, or stones. Pyuria is the existence of pus in the urine, and hematuria is the existence of blood due to urinary tract infection, trauma, or kidney stones. Fresh urine has a distinct but not repellent odor. However, bacteria multiply and they degrade urea into ammonia, and they produce kind of a pungent odor, typical of stale wet diapers. You may also have noticed that some foods impart an aroma. Perhaps you've noticed the smell of asparagus. Specific gravity. This is a ratio of the density of a substance to the density of distilled water. Distilled water has a specific gravity of 1.000, and urine ranges from about 1.001 to 1.028. Multiplying the last two digits of specific gravity by a proportionality constant of 2.6 will give an estimate of the grams of solid matter per liter of urine. For example, if we were to have a specific gravity of 1.025, we would multiply the 25 by 2.6, and that would give us 65 grams per liter. The osmolarity of urine can be as low as 50 milliosmolar per liter, or as high as 1200 milliosmolar per liter. So as you can see, it can be either hyperosmotic or hypoosmotic when compared to blood, which is 300 milliosmolar per liter. Then there's pH. pH can range between 4.5 and 8.2. It's usually about 6, where it's mildly acidic. We'll discuss the regulation of pH extensively in our next chapter of study. As far as the chemical composition that's normal in urine, it should be about 95% water, 5% solutes. And it's totally normal to find urea, sodium chloride, potassium chloride, creatinine, uric acid, phosphates, sulfates, traces of calcium, magnesium, sometimes some bicarbonate, certainly urochrome, and traces of bilirubin. However, it's abnormal to find glucose, free hemoglobin, albumin, ketones, bile, and pigments. These can be important indicators of disease. So as we've already discussed, the normal volume for an average adult is 1 to 2 liters of urine per day. However, sometimes we'll see diuresis or polyuria with an output in excess of 2 liters per day in individuals that are very well hydrated. If the urine output becomes less than 500 milliliters per day, it's considered to be low, and that's called oliguria. And extremely low is anuria, from 0 to 100 milliliters per day, and this is a dangerous condition. The low output from the kidney means there's disease, severe dehydration, circulatory shock, or there could be obstruction from prostate enlargement. And actually, a urine output that's less than 400 milliliters per day doesn't maintain a safe volume for removing wastes in the plasma. So elevated wastes will accumulate and serious complications can arise. Now let's visit diabetes. Diabetes, any metabolic disorder that results in chronic polyuria. There are at least four forms of diabetes, maybe more. 3 of them result in high concentrations of glucose in the urine, while 1 just results in more urine. So the first 3 are diabetes mellitus, there's type 1 and type 2, and gestational diabetes. Glucose opposes the osmotic reabsorption of water. So if there's extra glucose in the urine, then reabsorption of water is going to be much more slow, reabsorption of water into the tissues. And thus we leave more urine in the tubules, higher volume of water in the urine. It's called osmotic diuresis. And thus we'll see glycosuria as well as very high quantities of water, which can be dangerously dehydrating. Diabetes insipidus, however, is a result of ADH, antidiuretic hormone hyposecretion, so not enough antidiuretic hormone. And as you know, antidiuretic hormone is about water being reabsorbed. It places aquaporins in the cell membranes and helps transcellular transport of water. With ADH hyposecretion, you don't get those aquaporins, and thus you have lesser reabsorption, and thus we'll see more water passing through in the urine. But diabetes insipidus, we don't see glucose in the urine. Diuretics are any chemical that's going to increase urine volume, and you're probably familiar with a few: caffeine and alcohol, 2 big ones. So any coffees or teas that contain caffeine. And some of these diuretics will increase the glomerular filtering rate. So caffeine does this by dilating the afferent arteriole. When the dilation of the afferent arteriole occurs, then you have greater pressure in the glomerular capsule, and thus more fluid being pushed through the glomerulus. We can also see things that reduce the tubular reabsorption of water, because alcohol inhibits ADH. And if you inhibit ADH, as we just visited, then you reduce the reabsorption of water back into the tissues from the urine. So we see more water in the urine. Other, mostly drugs, act on the nephron loop. They're called loop diuretics, and they actually inhibit the sodium, potassium, and chloride symporter. And so that changes the countercurrent multiplier mechanism, and it reduces the osmotic gradient in the renal medulla. So the collecting ducts, unable to reabsorb as much water. Commonly, some of these nephron loop diuretics are used to treat hypertension and congestive heart failure because they reduce the body's blood volume and thus the blood pressure, and they relieve some of the symptoms. So there are several tests for diagnosing kidney diseases, evaluating their severity, and monitoring their progress. And in the next section here, we're going to examine the renal clearance test and glomerular filtration rate test. So to begin with, renal clearance is defined by the volume of blood plasma for which a particular waste can be completely removed in 1 minute. And it represents the net of all 3 processes: glomerular filtration of waste, then we add the amount of that waste added by tubular secretion, and then you remove or subtract the amount removed by tubular reabsorption. And that's our net renal clearance. We can't separate out those values. So to determine renal clearance, they collect blood and collect urine samples and measure the waste content in each. And measuring the rate of urine output, we can find what the clearance rate is. So we'll use urea as an example. There's some variables here that we need to understand. U is the waste concentration in the urine. V is the rate of urine output. P is the waste concentration in the plasma. And then, of course, C is going to give us the renal clearance in milliliters per minute of waste cleared. So let's say the urine waste concentration was 6 milligrams per milliliter, and in the plasma it was 2 milligrams per milliliter, and the rate of urine output is average about 2 milliliters per minute. So we can take U multiplied by V, so the waste concentration in the urine times the rate of urine output is going to give us how many milliliters per minute, milligrams per milliliter per minute that we're producing. And we'll divide that by P, the waste concentration in the plasma, which is milligrams per milliliter, leaves us with 60 milliliters per minute. And that means 60 milliliters of blood plasma is completely cleared of urea per minute. So we can compare C, the clearance rate, to the normal glomerular filtration rate of 125 milliliters per minute to see if the normal rate of clearance is occurring. And in this case, 60 divided by 125 liters per minute will give us 48%, which is normal for urea. The second test that we're taking a look at is glomerular filtration rate. Now, obviously, you can't go right in and measure it at the glomerulus. So if we need to measure a patient's GFR, we can't use a lot of substances. For example, urea, right? Some of it's going to pass through the glomerulus, but we're also going to see some of it being reabsorbed into the tubule, and then some urea is secreted back into the tubule, and so you have in and out movement of urea. And so this isn't going to, measuring it in the blood and measuring it in the urine isn't going to give us a reliable measure of glomerular filtration rate alone. So we need a substance that's not secreted or reabsorbed, and so that all of it that gets into the urine got there through the glomerular apparatus. And as it turns out, there's this really neat polysaccharide that's produced by many plants, such as garlic or artichokes. And it is neither reabsorbed nor secreted in the renal tubule. So all of it that gets into the urine gets there through the glomerulus. So clinically, though, it's not convenient to inject this protein inulin into people and measure its clearance rate. So we usually will use creatinine excretion as a measure of glomerular filtration rate. So that completes the section on urine and renal function tests. Now you're ready to go and take the Learn Smart module on McGraw-Hill's Connect.